Hi everyone, my name is Kathleen A, and this presentation is on Alzheimer's disease in the United States of America. The presentation will include background, risk factors for disease, prevalence of Alzheimer's disease in the United States, prevalence in urban areas compared to rural, prevalence between men and women, data sources that were used, analysis, results, limitations, conclusions, acknowledgments, and references. Alzheimer's disease is an irreversible progressive brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out the simplest of tasks. In most people with Alzheimer's, symptoms first appear in their mid-60s. Alzheimer's is the most common cause of dementia among older adults. The disease is named after a physician, Dr. Alois Alzheimer, who noticed changes in the brain tissue of one of his patients. She had died of what he believed was an unusual mental illness. Her symptoms included memory loss, unpredictable behavior and language problems. An autopsy revealed abnormal clumps called amyloid plaques and tangled bundles of fibers or tail tangles, which are still the mainstay for this diagnosis of Alzheimer's disease. This photo shows the significant shrinkage to the brain seen on imaging. In Alzheimer's disease, the loss of nerve cells in the brain is also realized. The cells are responsible for transmitting messages to the brain, to muscles and organs in the body. The damage initially takes place in the hippocampus part of the brain, which is the part that is integral in forming memories. This slide shows the classification and staging of Alzheimer's disease from the preclinical, where there are no symptoms but brain changes are seen in either neuroimaging or biomarker studies, to mild cognitive impairment, where those affected can still perform activities of daily living, to the later stages of dementia due to Alzheimer's disease, where cognitive decline is more pronounced and interferes with activities of daily living. The modifiable risk factors include heart disease, diabetes, lifestyle such as those that lead to heart disease. Examples of this include obesity and smoking, as well as head injuries. Non-modifiable risk factors include genetic influences, Down syndrome, age, sex, and family history. In 2018, records show that in the United States, approximately 5.7 million people are living with Alzheimer's disease. 1 in 10 people aged 65 or older has Alzheimer's disease. The percentage of people with Alzheimer's disease increases with age. And of those who have Alzheimer's disease, 81% are 75 years old or older. There's a big difference in the prevalence of Alzheimer's disease between men and women. 2/3 of the cases occur in women. 3.4 million are women compared to 2 million of men. Among those who are 71 years or older, 16% are women and 11% are men. There are higher rates of Alzheimer's disease in rural areas, 5% in rural areas compared to 4.4% in urban areas. This is believed to be because of less access to care, higher obesity rates, less education. Also, there are higher morbidity and mortality rates in rural areas compared to urban areas due to Alzheimer's. Whites make up the largest ethnic group in the United States, but blacks have 2 times the prevalence of Alzheimer's disease, and Hispanics are 1.5 more times likely to have Alzheimer's disease than whites. The proportion of white people with Alzheimer's disease who are 71 years old or older is 11.2, and the proportion of blacks with Alzheimer's disease aged 71 years of age or older is 21.3. This slide highlights the difference in prevalence in Alzheimer's disease based on race and ethnicity. In 2007, the CDC Healthy Aging Program, in collaboration with national experts, developed a 10-question behavioral risk factor surveillance system, BRFSS model, which measures self-reported increased confusion or memory loss and its associated effect. The CDC developed these survey questions because of the importance of cognitive impairment as a health issue and the recommendation to develop population-based surveillance. The questions developed in the questionnaire address how often increased confusion and memory loss causes individuals to give up household chores or activities outside the home, whether they need assistance and get the help they need, or whether anyone has discussed these issues with healthcare professionals. Memory problems are typically one of the first warning signs of a cognitive decline, possibly because of the development of Alzheimer's disease. The behavioral risk factor surveillance system is a proven data collection tool used in every state, the District of Columbia, and U.S. territories. It's a telephone survey conducted annually by state health departments and was established in 1984. It has three components: the core questions, which are asked either annually or on a rotating basis; optional models, each of which covers a particular topic in more detail and is developed by the CDC; state added questions determined by each state based on the health and data needs of the state. This module in particular uses the cognitive and caregiver models and has been growing. It was first piloted in 5 states: California, Florida, Iowa, Louisiana, and Michigan in 2009. It has grown. From 2011 to 2013, it was used in 45 states, the District of Columbia and Puerto Rico. 49 states used it in 2016. And between 2015 and 2016, it was used in 38 states plus the District of Columbia and Puerto Rico. Analysis: the CDC provides easy access to data through the Healthy Aging Data Portal. It provides information on key indicators of health. It includes subjective cognitive decline among older adults at the national and state levels. These indicators provide a snapshot of currently available surveillance information can be useful for prioritization and evaluation of public health interventions. The BRFSS is a partnership between the CDC and state health departments to produce data that benefits states, territories, localities, and public health professionals. And this slide shows the results of Objective 1, which is the prevalence rate of the Alzheimer's disease in the United States. And you can see on a state-by-state basis what that prevalence is. This slide shows the results of Objective 2, how do the trends differ between men and women, and you can see the prevalence of Alzheimer's disease is greater in women and men. And this slide shows the Objective 3, how these differ between rural and urban areas. And urban areas have less Alzheimer's disease than rural areas. Objective 4, does the prevalence rate differ based on race and ethnicity? And you can see in this slide that it obviously does, with African Americans being having the most prevalence of Alzheimer's disease. And the limitations. Because questionnaires are self-reported and not designed to assess whether or not the person has a medical condition or a medical diagnosis, the data is not intended to be reported as a prevalence measure of a medical condition, which is a huge limitation in this presentation. It is important to remember that the BRFSS is used to survey households and does not include residents of nursing homes, group homes, or other facilities, which is another huge limitation in this presentation, as a lot of those with Alzheimer's live in nursing homes. In addition, if the selected respondent is unable to respond to the survey because of physical and mental problems, the entire household is removed from the sample. Thus, respondents who complete the survey have been deemed by themselves or another household member to be mentally unfit to respond to the survey, which doesn't capture anybody with the later stages of Alzheimer's disease, as well as some of those with the middle stages of Alzheimer's disease. Conclusions and the next step. Public health agencies and private nonprofit and government partners at the national, state, and local levels are encouraged to work together on actions to make Alzheimer's the next public health success story. We can do this by using quick and strategic collaboration between public health and public and private partners to prevent cognitive health such as Alzheimer's disease from consuming the healthcare system. We can educate and empower the public about changes that should be discussed with healthcare professionals and benefits of early detection and diagnosis, making this less taboo for some people. We can promote the prevention of abuse and neglect and the exploitation of those with Alzheimer's disease and dementia. This slide shows the references that were used in this presentation, and I just want to thank everybody who has listened to this presentation and thank all of you and encourage you all in your endeavor. Thank you so much.